So indications first. So why would we feed the patient through a tube? So we have two tubes basically. So tubes that are for short term, we put two feeding tubes through the nose and into the stomach. Then we have long term, of course, we feed it through a small stoma through the stomach. There are several purposes for this. We have the purposes in table 39-2. Again, this will be short-term or long-term purposes. Alcoholism, cancer therapy, the list goes on. So we have several ways. So if the patient has any of these conditions, including let's say, look at under maxillofacial or cervical surgery. So the patient lost the ability to chew and swallow, right? So they can't do that. So now we have to, but the requirement here is that the GI tract is functional, meaning they have bowel sounds, they have peristalsis, they have the ability to absorb nutrition. Okay, so if that's all intact, we had just have these problems, they can't chew or swallow, or most of these are caused by inability to chew or swallow. Let's say here, anorexia. I mean, are they gonna swallow? They may chew, but not swallow, or they may have the ability to chew or swallow, but is it enough? Let's say you have a dementia patient, stage 4 dementia. There's plenty of food, but will the patient eat it? No, because now they have agnosia. They don't know what to do with the food. You give them a food tray, they don't know what it is. Then would they know what to do with it? No. Okay. So various conditions, but the requirement here is that the GI tract otherwise is functional. There's no absorption problem. There's no elimination problem. Okay. So we can eat, but the patient does not eat or chew for various reasons, okay, listed here, okay? Or maybe they eat and chew, but not enough, okay? Too weak or too mental style, mentally unstable, okay? Right. So I'm not testing you on the formula because we are not the nutritionists, so I'll skip through the formulas. But be aware when it comes to formulas, these are prescribed by the nutritionist. All right. So the doctor will make a referral to the nutritionist once they establish that the patient needs short-term or long-term feeding. They will ask the nutritionist to come in, see the patient, evaluate, and then the nutritionist will make a recommendation as to which formula to use. So there's formulas for people with kidney disease, with diabetes, all sorts of conditions. Okay, so the nutritionist is the expert. Okay, the doctor defers to the nutritionist, and then they make the recommendation, and the doctor makes it formal by writing the order. Okay, but technically the doctor never decides. It's the nutritionist. All right. So we have two methods to do the feeding. Either we do it with the manual, cyclic feeding, or we use a pump to feed the patient continuously. Again, the nutritionist will make the suggestion, and then we follow. There are two. Let's start with nasogastric first, the ones we put through the nose. Now there are large bore, larger than 12 French. So the largest small bore nasogastric feeding tube you can use is a 12. Okay, so we have 12, and then it'll go 10, 8, etc. Of course, anything you put through the nose is uncomfortable, much less if it's bigger than a 12 French. Now, to give you an idea what a 12 French size is, the cable, not your charging cable, but that's too small, like this cable. Okay, so this is a 12 French feeding tube. So it can easily get clogged. So be careful when you give medications to it. Formula, no problem, because there are no clumps there. Formula is an even solution. Okay, nothing solid in there. Problem comes when you administer medications to this, because you're in a hurry. Like you don't crush the medication, or you don't wait, you don't prepare it in advance that you're in a hurry. Okay, and then you haphazardly, dissolve it. Or sometimes you take a shortcut. You're supposed to give one medication in one cup, not a bunch of 10 medications in the same cup, right? So now you clog these things. And then every time, guess what the doctors will say? Because every time it gets clogged, and then you say, "Oh, it was fine a minute ago. Then it just got clogged, doctor." What do you think the residents will say? Who else did this? Okay, it's not that the patient administered anything. It's the nurse that did it. So of course it's your fault, right? Somebody, it may not be you, maybe the previous shift, all right, could have done it. But the point is, nasogastric feeding tubes are small bore, so they are not really friendly with crush medications. It's fine if the medication is liquid, then that's absolutely fine. But when we crush medications, better make sure you dilute it enough. Okay, and then follow the rule, which is 1 tablet per medication cup. Okay, and we'll go through because of course the rule is you flush in between, yeah. So you give water first, and then the dissolved medication, and then water again in between medication, because it'll be too much liquid. Now let's say you have 10 medications, because we're supposed to flush with 30 ml. Now we have 20 medications. How many ml is that? Okay, so we are allowed 15 in between medications so that patient won't get bloated too much. So the most common type is the Dobhoff. Let me show you what it looks like. It's pretty common. In Florida, we insert these ourselves. So nurses put them in, and you need a doctor's order to confirm placement. So this is what it looks like. This one. So it just comes in a no, a clear plastic bag. It'll say the size in the package, 12, 10, 8 French. So most adults, we use 12 French. So that's the biggest one we can use. You see there's a metal at the end. Okay. And here, when it's not used yet, there's a wire inside it. A wire. You know what a wire is? Like a steel wire. Okay. So you need the steel wire and the metal weighted end. Make sure it stays down, because otherwise, if there's no metal, what will this noodle do? It will just flop around. So there's a metal at the end. So make sure it stays down once you've inserted it. Now, when you insert it, so let's say you work a first facility that you insert it, just like any other tube, NG tube, you put it in. Okay, so ask the patient to swallow, swallow, swallow. So you'll give them water to sip. Okay, swallow. It goes in easier with a human person than on a mannequin. So as long as the patient is cooperative, you should be able to put it in. And then once it's in, don't leave the wire in, because you need X-ray confirmation first. So once you get the chest X-ray, radiologist says, okay, it's in the stomach, or wherever it is, it's in the small intestine, okay, wherever the doctor wants it. Okay, then you can remove the wire. Okay, you just pull the wire slowly. Then it's ready for use. So you anchor the tube. We usually use commercial tube holders, or if you don't, use Steri-Strips. Steri-Strips stay on better than regular tape. And there you go. The feeding tube is ready for use. So this is only for short term if it's nasogastric. So we're talking ICU patients, we're not talking long term, like months or years. Okay. So this is only for short term use. For anorexia, depends. If the patient has been in your care for a long time, I mean, they don't respond to psychotherapy or whatever, yeah, they'll have a peg tube, which is now for long term. Okay, so for our hospitalized patients, because we don't do cyclic feedings, we use for acute care, for all our patients who are admitted, we use continuous feedings, meaning this will run for typically 22 hours. They get 2 hours rest. In long-term care, it runs around, who works in long-term here? Yeah, around 12 or 16 hours. So they have around 8 hours of a break. And then they go to the day room, right? Or wherever socialize without the pump or the feeding. Okay. So that's how it is in the nursing home. You can also do bolus feeding, bolus or intermittent drip. When we say bolus, they are given commensurate to the meals of the day. When do you eat? Breakfast, lunch, dinner. Okay, so it's the same. So when we say bolus, then that's how it's given. So it's either 1 or 1.5 cans, 2 cans, whatever the nutritionist prescribe, because the nutritionist will decide how much calories this patient and requires depending on their activity level. So they prescribe how many cans and which formula. Okay. So if it's bolus, then that means you don't have a pump. You simply have the syringe, okay, the 60 ml syringe, and then you manually pour it, okay, by gravity. You can push it a little bit if it's, if the gravity is sometimes especially again, if you screw up, you put a little too much medications there, then you're allowed to put in the plunger and then push it. Okay. So it could be 4 to 6 feeds throughout the day. Again, depends. Okay, the doctor, I mean the nutritionist will order the patient's feeding based on their metabolic requirements. Please don't forget that even though we're doing formula feeding, doesn't mean the patient doesn't need water. Okay, so just like you and me, they need how much water? Okay, same amount. Okay, so we give them water. So don't forget to flush. The doctor will order the amount of flush and how often it is done. Okay, but always use your judgment. Okay, patient clearly is constipated. Are we giving enough water? So clearly we're not. And again, always use judgment. Just because it's ordered, do you give it if the patient is not emptying? No, you always assess. Okay, so let's go to the responsibilities now. Right here, chart 39-5. So this is the bolus feeding. So the patient can do it themselves or by the caregiver, or that would be you. Now, these pumps and the tubing is designed in a way that you cannot possibly administer it intravenously. Okay, the ends are not the same. There's no way you can connect it to a luer lock. Are we clear? Okay, they did that on purpose because could you mistakenly give these intravenously? Yeah, God forbid. Yeah. So yeah, if you work hard enough, you can actually, some psychopath really, wants to kill a patient. Yeah, they can do that. Okay, they can simply transfer it to the formula into an IV bag. Okay, you can do that. For psychopaths here, I need to know now. That way we don't give you a license. Okay. Okay, so these are your responsibilities. First is, and this is not one time, this is every time you start a feeding. Tube placement, paramount. So you check the placement of the tube. There are 3 ways to do this. What did you do or observe in the nursing home? How did you, no, tell me the truth. How did you, okay, you used air insufflation, yeah? So you put 30 ml of air, you put your stethoscope and then, okay, all right. Technically, that is not evidence-based because they've proven, they did research that regardless of where they put the tube, whether the tube was in the lung, in the esophagus, in the stomach, the whoosh sound was heard. So did it really confirm placement? No. So is that practice evidence-based? Clearly no, yes. Okay. Okay, so that's one way, right? Air insufflation. But is that based on evidence? No. Okay. Air insufflation. Is that based on evidence? No. Okay. So the second way to do it, and ideally, is the aspiration of gastric contents. So when we aspirate the gastric contents, so we put that in a small cup and then we test the pH. pH of the stomach is usually acidic. So anywhere between 0 to 6, but typically it's around 3, 3 and 6. So if it's not acidic, where could that 2 be? We don't know, but we know it's not in the stomach. Are we clear? All right. Correct. So if the placement is a issue, meaning you suspect or it's questionable, what should you do? Yeah, you get an order. So you tell the doctor your findings. Okay, I can't be sure, doctor. Need your help. So they'll order, okay, let's do an x-ray. So x-ray would be best, right? Because we can literally see where the tube is. So x-ray shows, okay, it's in the stomach. Go ahead, use it. Okay. Another way, of course, is the x-ray. But we can't do x-ray 4 times a day, can we? No, that's too much radiation, it's very costly. So the other way is to check for the presence of CO2. Okay, so we use a capnometer and we put it at the end of the tube. If it detects high or normal levels of CO2, where is that tube? It's in the lung. Should there be CO2 in the stomach? Yes, but not at that level. Okay, so CO2 is in the stomach, but not really in normal or high levels. Should be very minor. Okay, are we clear? So what are the 4 ways? Air insufflation, which is very unreliable. Next is the pH of the gastric residual and air, what? X-ray and okay, and let's call it end-tidal CO2. And like N, the N, and then tidal, like tidal wave. Okay, end-tidal CO2. All right, so those placement and then position. No patient on a feeding must be positioned less than 30 degrees. Okay, the head of the bed must be at least 30. Unless you're changing them, then the feeding must be stopped. Okay. Okay, ability to tolerate the formula. Now, is it true that patients on formula feeding get diarrhea?
Yeah.
Babies get nothing but formula too, or breast milk. Do they get diarrhea all the time? No. I have 4 kids. None of them had diarrhea. They had solid or soft feces. Explain that.
Because the content.
So is the patient with on a formula feeding expected to have diarrhea? No. So let's look at the complications later. There's a table for that, making it simple for you, but there should be no diarrhea. Okay. And we'll look at what to do if they have constant diarrhea. So these are some of the intolerance. Okay, so fullness, meaning the stomach is not emptying. The formula stays there. Bloating, distension, nausea, vomiting. And then again, we'll look at constipation and diarrhea later in the table. Responses, we have to evaluate, are they getting enough nutrition or are they getting too much? So what would be the best way to evaluate this? Okay, we do weekly weights though. Daily weights are not relevant. Okay, so it has to be weekly weights. It's different in heart failure patients because what were we evaluating there? Fluid volume, right? So if you're evaluating fluid status, we do weights daily, but this is nutrition, so we do weekly weights. More reliable findings besides the weight are, of course, your lab, especially the albumin and pre-albumin levels, protein. You can also add their hemoglobin, hematocrit, because these are all signs of malnutrition, right? If they are abnormal. Signs of dehydration. We already did this in module 1. Or overhydration also can go both ways. How much formula was fed? Okay, that's per shift. And then glucose, because this is artificial nutrition, so it's not really the same as our food, especially if it's continuous. Because now, do you continuously eat?
No.
No, you have to stop, right? And then you have to sleep. So therefore, do our pancreas learn our patterns? Okay, so when you put the patient on a continuous feeding, what does that do to the pancreas? Pancreas is confused. What is this? What am I doing here? Okay, so now there will be some sugar imbalances. Okay, so you need to monitor that. Signs of infection, because the rule is since we're hanging a bag, now there are two ways to do continuous feeding. You can have a commercial formula. So when you do closed system, the formula is in a bottle, not a can. Okay, here. So these are the bottle formulas. Okay, they come commercially prepared. And the tubing, you spike it. It's not, again, it's not the same as the IV spike. Okay, so this one will have a cross in it. And then the opening on top of this bottle is also cross. Okay, so they match. Okay, so if you use an IV tubing, it's not gonna fit. Okay, so this thing has a separate dedicated all formulas, regardless of the brand, whichever company, it's standard. Okay, because it's standardized by the FDA. So you do that, you spike it just like a IV. Okay, of course we have a different feeding pump, so it has a slightly different mechanism. So that's a closed system. Okay, we use that. However, there is no bottled water though. They don't have the same one, no bag, commercial bag for water. So the water part, which flushes the patient automatically, is an open system. Now the if that's the setup, you have to put no more than 4 hours worth of liquid in it. Same thing if it's an open. So let's say in the lab, you've seen feeding tubes, yeah? Because we don't have a closed one. All we have in the lab is open. Whether it's formula or water, you should only put 4 hours worth of liquid there. Don't put the whole 16 or 12 hours worth of feeding there, because what will grow in there? It sits there. Any liquid that you put in a room temperature, what will that liquid grow?
Yeah.
Bacteria. Okay, because it's not airtight. Okay, so that's the rule. Only how much? 4 hours. Then after 4 hours later, of course, you add more. Okay, but only 4 hours worth at a time. Right here. So if it's open system, only 4 to 8 hours. So therefore, you also check the patient for signs of infection every 4 to 8 hours. All right, let's on your residual volume, your textbook says 250 ml, meaning if there's 250 ml or more, first of all, what is gastric residual volume? This is the volume of formula in your stomach at any given time. So because the formula, let's say it's running at continuously, most facilities have a maximum of 70 ml per hour. Okay, I've seen, really large patients, that's the maximum we can give. So most average patients have a goal of 50, 55 ml per hour. So if it's really big, the maximum we can give is 70 ml per hour of formula. Now, if it's running continuously, should it really sit in the stomach? Because 70 ml is put into the stomach every hour. Should it really stay there?
No.
No. Plus, it didn't like dump 70 ml at one time. It dumped a few at a time, but the total is 70 ml every hour. So that 70 ml wasn't dumped there at one time. So it was trickling slowly in an hour. So therefore, should it sit in the stomach? It should continuously go forward to the small intestines, right? And again, get absorbed. Now, so therefore, if it's sitting there 250 or more, is that a problem?
Yes.
That's a big problem because again, think about how we're feeding the patient. Again, you did not dump the let's say you checked it, because we're checking it every 4 also. You did not dump 280 ml there at one time. Of course, if you dump for 280, yeah, you'll see the 280 sit there for 1.5 hours. But this did not. This was continuous. Okay, so is it a problem if there's 250 or more? Okay, what do you do then? Okay, stop the feeding, call the doctor. Okay, because it's not safe. Because should you continue feeding? No, there's something wrong. Patient is not emptying. Are we clear? So that's checking the gastric residual volumes. Now, every time how did you measure the gastric residual volume therefore? How did you know there was 250 in there? What did you do? You aspirated. So after you aspirate, what is in the tube now? The formula. So what should you do before, especially after checking residual? Flush it with water. Okay, how much again each time? 30. You only do 15 between medications. Okay, but each time, so you check that before each feeding or continuous feedings every 4 hours. Okay, so you check that. Are they emptying? Next, I know, very important. And then, like we said, weekly weights. Any questions? Okay, let's go into more details now. We already put the indications earlier, yeah? For who gets the feeding? Yeah, okay.
What's the air thing called again, Professor? The air
Air insufflation. Okay, so here's now the 250. Okay, of course, 250 is minimum, maximum 500. Okay, so that indicates, yeah, feeding intolerance, meaning they're not emptying. Okay, let's go to maintaining the patency of the tube. Now, it's very important to make sure it's patent and it's working. Formula can go in, medications can go in. So we said 30 ml of flush. So when do we flush? These are the times that we flush. We flush with 30 ml when? Before and after. Okay, keep it going, children.
Before administration. Checking the residual. Checking the volume.
Every 4 hours for continuous feedings and when the tube feed. Okay, so meaning the doctor ordered the feeding stop. Maybe the patient went for a test or went for surgery or whatever. When the feeding is interrupted, you always flush. Why? Do you want water in the tube or formula? Well, no, in the tube when it's not being used. You want water. Just like your IV access. If you gave an antibiotic, do you want antibiotic in that extension? What do you want in there? Normal saline. All right, same idea. Okay, we don't want it because what will the antibiotic or in this case formula do if it sits there in that tube? It's gonna clog the tube. It's gonna dry up. Okay, it's gonna clump and then obstruct your tubing. What do we flush this feeding tube with, by the way? You drink distilled water?
No, just regular.
What does the patient drink? Water.
Isn't it in the? So where you get the water from?
You can use that, but you drink sterile distilled water?
So tap water?
No, tap water is fine.
I don't think so.
Right.
It's just as good. Who drinks sterile distilled water here?
You can.
Water. I thought
Yeah.
this
It's fine. It's in the hospital. Okay, the hospital uses that, but do we really need to? All right. So, however, in the hospital, we use sterile distilled water. Okay, fine, give that. But if this patient at home, do we need that? No, we drink water. So no saline, okay? Because before somebody answered saline. Drink saline? So here they are, the options. So drinking water, or if you want, purified water, sterile purified water. Okay, the best practice is sterile water. But do you have to? So this one, especially if, of course, if your patient is immunocompromised, then the any water other than bottled or sterile water is a potential contaminant. Especially if it's already sitting, open container. Like I said, for medications, how much do we flush in between? 15 ml. So that says there 15 ml. And then if it's not liquid form, what should you do with the powder? Okay, really, okay, should be crushed finely, fine enough to snort, and then do not mix it because some medications, most medications dissolve fine by itself, but when you mix it with other medications, then they do not dissolve now. They get clumpy. Okay, so that's the reason why we dissolve them separately. But ideally, again, it should be in a liquid form. Okay, that's the best practice.
Oh, okay. Why, they still, distribute, our pharmacies still distribute, they know that the patient is GT.
Because they don't come in a liquid form. Some of them
So
don't
you still
come
have
in a
to get the
liquid form.
enteric-coated crush?
Well, no, of course, enteric-coated medications can't be crushed, so you have to, we can't give those.
But
Through a
they still
tube.
order them, doctors still order them.
How do you get, well, that should be changed. Then the doctor, I mean, no nurse would administer that. Because how do you give the enteric-coated, how do you crush it? You can't. Capsules, you have to consult. Okay, very good point. For capsules, you have to ask the pharmacy if it can be open. Okay? Because some capsules can be, let's say, Flomax, tamsulosin for prostate, because it doesn't come in any other form. There's no liquid tamsulosin. But the pharmacy said, yeah, it can be opened and dissolved in water. Same thing for Prilosec, okay, or omeprazole. So some capsules you can open and dissolve, some you can't. So consult the pharmacist. If it's not and available in other form, then tell the doctor that you can't administer it. Okay, formula. Not all patients, of course, if it's only, let's say, 50 ml per hour, the formula is 2 liters. So therefore, can you finish the 2 liters in 22 hours? Do the math. 50 ml per hour times 24 hours. Clearly no, right? You got what, 1200 ml? So you have leftover. So what do you do with it? Discard all formulas, all equipment. Okay, the formula, the tubing, any equipment you had open. Let's say you open a sterile distilled water bottle yesterday. So all of them should be dated. Okay, so every time you open a container, you start using it, put the date. When was it? Expired 24 hours later, discard. Okay, same goes for refrigerated formulas. Let's say it's in a can, so can only be refrigerated up to 24 hours. How it happens is it's usually the night shift's job to discard everything. Okay, meaning it's expected already that, oh, you're the night shift, you're supposed to discard that and hang new one. So when the day shift comes in, a new formula should already be there. Okay, that's in the nursing home. In hospitals, well, it's whenever the date is because we admit patients 24/7. So it's whenever the feeding was started. Okay, here's now our bowel elimination pattern. So these are the possible problems. Intolerance, which is usually manifested by diarrhea. C. diff is also possible, especially if the patient is on antibiotics. So that diarrhea could be C. diff. Dumping syndrome is usually caused by formula intolerance. So when the patient has dumping syndrome, and these are the manifestations, it's basically a combination of hypoglycemia and dyspepsia, and these manifestations, cramping, abdominal pain. So when they have dumping syndrome, the patient will be switched to a different formula. Okay, we can't continue with the same formula. And contamination, of course, you didn't wash your hands, you contaminated equipment, or the equipment and formula has been hanging for too long. For constipation, these are the causes, but if you want a summary, here's the summary as I mentioned, table 39-3. So it comes from constipation, lack of water or fiber, diarrhea, intolerance of the feeding, or it could be infectious. Bloating could be from dumping syndrome, nausea, vomiting, same. The more serious complications are the following. So you've got aspiration pneumonia. This can cause sepsis. This one is for nasogastric feeding tubes, local irritation, especially if the tube is not secured properly, or the tube is too big, or the tube's been there too long. Displacement can cause aspiration as well. So what do we do again before using the tube? Okay, check for placement. Obstruction, whose fault is this? Okay, so one of us clogged the tube. No matter how much you deny it, you say, no, I didn't do it. Of course, evidence, what's that term? Latin term? Res ipsa loquitur. Okay. Yeah, the obstruction speaks for itself. The thing speaks for itself. That obstruction, who else could have put it there? Okay. So you can't win in a lawsuit with that. I mean, there's no way. What other cause could there be? Okay, it's us. It's one of us. We obstructed the tube, and the patient paid for it. Okay, so we got hyperglycemia. This is again because, or it could be hypo also, can lead to dumping syndrome. For hyperglycemia, no, the calorie content of the formula is too high. So the nutritionist has to make adjustments. If it's hypo, then it's either, too low, or could also be dumping syndrome.
So there should be no reason why a person is getting fluid either through the nasal or should be no reason. Diarrhea.
Yeah, always, consider infectious or could be feeding intolerance.
Is the dumping syndrome going into the
Now it's like this. Dumping syndrome is because, are we used to eating liquid food? No, it's supposed to be formula. I mean, solid, right? So food is supposed to sit in the stomach for 1 to 1.5 hours, and then it proceeds there. So dumping syndrome is because you're eating liquid. It goes straight into the duodenum, and then your pancreas did not have time to adjust. So it causes a sudden hyperglycemia, right? Because you dumped it straight into the duodenum, and then rebound, of course, what will the pancreas do? Dump insulin as well. So that goes hyper, and then sudden drop of hypoglycemia as well, because of the reflex reaction by the pancreas.
in that case, patient getting
No, not with dumping syndromes. That's why we switch formula when that happens.
So-
There's no way, there's no adjusting. Okay, we can't say, oh, he'll get over it. No.
person is getting have diarrhea. Are they getting the nutrients or is it just like
Of course, diarrhea means it's just going through the patient. Yeah.
So
And plus, they're losing fluids as well and electrolytes.
combination of any of these things that you said?
Mhm.
Tolerance.
Yeah, so that's why I said the manifestations of the dumping syndrome are exactly how I described it. Yeah, there's a sudden hyperglycemic episode and then followed by a sudden hypo as well, which is very uncomfortable. Sorry about the recording because I was concentrating here and I didn't move the screen here. Okay, but just
But was it recording though?
it's recording, but it wasn't doing the same thing.
So.
The screen, yeah, I'm talking because I'm moving this screen. I wasn't moving this one. All right, let's finish up now. So for preventing dumping syndrome, you have chart 39-6. I won't read them for you. It's pretty simple and self-explanatory. That's about it for... let me make sure because there shouldn't be any difference if it's a jejunostomy, because this part here talked about gastrostomy tubes. So this one, okay, so these tubes are, no, I remember now. So that first part was talking about nasogastric feeding tubes. So these are now for long term. So these are now gastrostomy and percutaneous endoscopic gastrostomy tubes, or PEG. The PEG tube is done under, I mean, inserted in uh, endoscopy unit. So the doctor either uses a push method or a pull method. I won't bore you with the details about insertion because we're not the ones inserting it, but just know that the PEG tube has a bumper outside and also inside. Bumper is like a stopper, okay, preventing the tube from moving. Okay, so it secures the tube. If you can adjust it, okay, you can move the bumper, but not the internal bumper. The internal bumper can't be moved. The outside you can, so that you can clean. So you move the bumper, you clean around the tube, and then push the bumper up against the abdomen when you're done. So these are bigger tubes because they're for long-term use. So they can last, look at this, with optimal care, these tubes can last 1 to 2 years. Okay, as long as you take care of it. Keep in mind also that regardless of the push or pull method that was inserted, the only thing keeping the track open where the tube is the tube itself. So what will happen to the opening once you pull the tube? Let's say this patient's confused, pulled it out. What happens to the track? It starts closing. Plus, you can't really reinsert it because are the layers, because is there only one layer we're talking about here? No, because there's the skin, there's the epidermis, there's the dermis, there's the hypodermis, there's the subcutaneous layer, there's the fascia, there's the muscle, there's the peritoneum, and then there's the stomach. So are these 8 layers aligned? They slide over each other. So therefore, are you guaranteed the track remains open after they pull it? So the first thing is, of course, you have to assess your patient. Is the patient with it? Okay, so if they have any mental status change, secure that tube. Okay, put a binder, whatever you need. Okay, mittens on the hand, whatever your facility allows. So here are the layers I talked about. So there's a internal and there a external bumper. Okay, for the PEG tube. And here are the layers I was talking about. So the track isn't always aligned. Okay, it was just aligned on insertion, but after that, they keep sliding, depending on the patient's position. So jejunostomy tube, that means the tube is in the jejunum, but the care is the same, right? So what do we do before starting the feeding? Placement, how often do we flush the tube? Okay, every 4 hours, and then same 4 ways to check. Oh, well, for PEG tubes and gastrostomy tubes, there's not likely a displacement issue here, unlike the nasogastric, because where else could it be? Okay, the exception is, let's say, what if the tube was partially pulled? So we do still check placement, okay? But as far as the end-tidal CO2, we don't have to do that, okay? But we do the other methods, you know, the aspiration of gastric contents, we still do that. And X-ray. Okay, that's it. Let's do the